be transitioning to our 201 session. And we, in this session, will have Lori Oliver and Garrett Jackson participating in this session, and I believe Jonathan and Ryan will also be continuing to share a little bit of their expertise with us as well. So I will hand the floor, the proverbial floor, back over to our faculty from Polsinelli.
I hope everybody can hear me. So my name is Garrett Jackson, and I am in our St. Louis office by way of introduction. I have the pleasure of introducing the portion of the presentation today where we'll concentrate on value-based care and value-based contracting. In the interest of time, I know we only have about until 7:30 Central to work through quite a bit of content on this front. So I'm going to try to keep our introductory portion as brief as possible. Over the course of this portion of the presentation, we're going to try to walk through some of the general background regarding value-based contracting with the ultimate goal to ensure that you have a basic understanding of the intent and history of this type of contracting approach, and also ensure that you understand some of the most recent trends, most frequently used value-based models, and some advice from our experience in contracting on this front as well. Hopefully we'll be able to leave a good portion of time to address some of the practical tips today. In terms of the history, it's really important to recognize, especially in my opinion, since it's been the most common area where I have practiced, that much of the history of value-based contracting efforts really originated on the federal side. And there has historically been this really significant concentration, as is indicated on this slide, which originated in 2007, on what was, or what is frequently referred to as the triple aim, which entails this move from traditional fee-for-service contracting to concentrating on a variety of contractual efforts to effectuate better care for individuals, better health for individual populations, lower per capita costs, and then most recently we've seen a real significant concentration, especially over the course of the last year, on both concentrating on work-life balance for clinicians, but also concentrating on various just social determinants of health and how these programs can impact them as well. In 2010, the ACA established a more formal concentration on value-based care and established what's called the CMMI, or Centers for Medicare and Medicaid Innovation. And it's through CMMI that we see development of many of the federal programs that have served as the foundation or as an example for what ends up being adopted quite frequently on the commercial side. In terms of the kind of broad overarching question of why would any of the commercial payers or federal programs concentrate on these types of programs, the primary driver, as noted previously, is this just continuing inflation in healthcare costs that impacts both the commercial payers' bottom line and then especially the federal programs' ongoing viability. In terms of the primary concentrations of many of the federal programs, it's really concentrating on that intent of primarily impacting overall costs, but at the same time concentrating on increasing quality and especially recently, as I noted before, increasing equity and addressing social determinants of health at the same time. In terms of big picture trends, I want to quickly hand the floor over to Lori, who's going to talk a little bit about this. But I do want to note that we're going to try to really collaborate in the context of this presentation, and you'll hear from me again on some of the federal programs as well. So with that, I'll let Lori take over, and we'll kind of bounce back and forth a little bit in this presentation portion.
Terrific. Thanks, Garrett. And good afternoon from Seattle, Washington to everyone. Want to kick off a little bit on big picture trends and pick up on some of the conversations that we were having with Ryan and Jonathan. So we are seeing and expecting to see an acceleration of employers and commercial payers that are implementing value-based care arrangements. And we're using the terminology value-based care today to mean non-fee-for-service, generally speaking, and ways to pay providers for the value of the care they deliver rather than a per-click type payment. And we've talked a bit about payers and their emphasis on cost. So they are definitely looking to providers to accept more responsibility and risk associated with the care. And in part, perhaps for altruistic reasons, and in part because it's a pretty documented connection with cost, we're seeing models evolve that are trying to tackle non-medical matters and social determinants of health programs, not just care coordination, but nutrition education, substance use disorder support, early childhood resources. There's a wide variety of types of programs that are being built into models, particularly by public payers, but also private payers, trying to get at the issues that surround why care costs so much in the United States. These approaches are all going to require collaboration with other providers and payers, both at the individual clinician level, institutional and regional, and again, the continued push to drive down the cost of healthcare. I would agree with Jonathan. We're also seeing an increased focus on quality at the same time. And with regard to telehealth, given the questions that came up, I wanted to highlight in the latest physician fee schedule that Medicare has really signaled its commitment to the continued delivery of care through telehealth modalities. And it has given a firm date for trying to submit evidence to convert care that is listed as Category 3 on the telehealth provider list into Category 1 or 2. So there is a commitment to telehealth, and in the behavioral health space in particular, we even see that expanded to audio-only care. Whether other payers follow that remains to be seen, but I did want to highlight that in light of the questions that we'd had. Thinking about Medicare fee-for-service, I'm going to kick this off and then turn back to Garrett. But if you think of this in the last decade, CMS through the CMMI, Centers for Medicare and Medicaid Innovation, they really tested over 50 different models that had some value-based care element. And they recently paused and prepared a report that you can find on their website calling it's their strategic direction white paper. But they really highlighted their key learnings from this last decade that are setting the stage for the next decade to come. So some of that related to the importance of multi-party alignment to really shift the entire marketplace into value-based care, not just one payer here, one payer there. Again, a significant focus on equity. The data is showing that not all their beneficiaries are being benefited equally by these models or included. No surprise to the providers on this webinar, they need to reduce the complexity was one of their findings, including in the benchmarks, the risk adjustment methodology, kind of across the board, the models are too complex. I was really pleased to see a recognition that providers need access to tools that will help them manage a different type of reimbursement model, including predictability for investing in those models. So I think all those learnings will help inform what they are looking to for the next decade, as they have articulated we must move faster to move the market into value-based care. So I expect an acceleration of this process. And they've identified 5 objectives that are going to guide their activities. And they have goals for both the provider, the beneficiary, and for the market. So the bullets on the screen are their 5 strategic objectives that they have articulated. And I'll leave you to read those bullets, but I wanted to highlight on the support care innovation, the 3rd bullet. They're really focusing in on integrated whole person care. So that means social determinants of health. It means bidirectional integration of behavioral health with primary care. It means a lot of different things depending on the context. So I wanted to flag that, and also on the multi-payer alignment to transition the system. So I expect to see CMS making efforts to bring other payers, commercial and otherwise, along in a consistent fashion to the extent they can. So I'm going to turn it back to Garrett, who's going to give us some updates on the models that are currently in place in the fee-for-service world.
So I'll just add and quickly kind of supplement Lori's comments that in terms of the discussions that we've had recently with CMMI, one of the additional things that they're really going to try hard to address is overlap between these programs, because what both physicians and hospital-based program participants have seen is that it's really difficult to determine if you are participating in the shared savings program, which one of your beneficiaries are potentially going to be attributed to that versus potentially a overlapping BPCI participant that's in your same geography. And it's been really difficult for us as legal support for our participating entities to discern that, because it's been hard for CMMI to clearly state what their rules are. So that's one of the other things that they're trying to address recently. Historically, there was this hospital-centric concentration that was coming out of the CMMI programs and some of the regulatory-based programs that were released in the prior administration in like 2015 and 16. And in the last administration, we saw this pretty significant change in concentration from mandatory programs like the CJR orthopedic program and some that were released and then canceled in the cardiac space, to much more voluntary-based programs and publicizing as many as possible to try to encourage participation. Because as CMS has recognized, there's this tension between the desire to move you as a provider into APMs to try to mitigate some of the heavy lift that macro obligations can create. But now what they have established by putting many of these programs on pause, especially limiting the enrollment opportunities over the last 18 months, there's very few new opportunities to participate in APM or programs that qualify as APMs currently. So as Lori indicated, everything has been kind of put on pause while they do this sort of refresh and analysis of what has worked and what has not worked. But what we're hearing in terms of likelihood over the next 12 months is that there's going to be kind of a renewed concentration on some of these mandatory programs. There's going to be an expansion of some of the historic bundled options that they've seen the most participation in historically. And we do anticipate that there will be some increased opportunities, but likely not until 2022 at the earliest. What we have seen, as especially the last 2 or 3 years have gone on, is that previously the federal programs are really driving the innovation in this space and serving as the foundation for what was adopted in the commercial space. And now that CMMI has kind of exhausted some of the rollouts of those new programs, we're seeing a lot of the innovation happen on the commercial side instead. So with that, I think it's a good transition to hand the floor over to Jonathan to talk about some of those commercial payer trends in this value-based care space.
Thank you, Garrett. I think we see some fairly indicative trends in the value-based space with commercial payers. And it's not just straight capitation anymore, and ACOs are not just for Medicare anymore. We see a lot of investment by payers, and it's translating into the number of arrangements with value-based components to them, definitely increasing across the board. The form and the structure of these arrangements continue to evolve, but you'll hear the different models as we talk about them a little bit later, that they're all, any arrangement can have any sort of components to them. So there's really no one-size-fits-all approach on the commercial side, but the opportunities are definitely there. And I note here that downside risk remains a challenge, I say it remains a challenge because all the payers who are doing value-based arrangements are wanting to increase the amount of downside risk that a provider agrees to take on. And lots of providers are resistant to this without knowing how it's going to bear out. So oftentimes I see providers entering an arrangement with only upside risk at the outset, but after a year or two, the payer is insisting that they take on some downside component to it. Population health through proactive care management, that's really taking off in the commercial space. And you'll see not only the reimbursement for the healthcare services per se being innovatively compensated, but you'll see a lot of care coordination, care management service fees paid on a per member per month basis, in addition to the services compensation. Clinically integrated networks are forming a very significant and critical component to these arrangements. And if you're a community physician in a smaller community, but there's a large health system there, I'm seeing a lot of CINs who may have a large participation from, the health system's physicians, but they also definitely rely on and include the community physicians too. And so that's an opportunity to participate within your local communities. The other kind of trend that's really taking off is employers are contracting directly to participate in value-based care. And this can be in a variety of forms, but the crux of it is self-funded employers no longer want to be at just the mercy of what an insurer or their TPA is doing. They want a bigger hand in the table in how their funds are expended, and think that they can help through some of these innovative models control and even reduce the cost of care from prior years. The percentage of increase in costs year over year has gotten untenable for employers with self-funded plans. And so they're very definitely willing to engage in these. So here's some of the examples that we're seeing around, and all these payers have essentially even a devoted page on their internet website to what they're doing in the value-based care space. So if you're curious about a payer, don't hesitate to look up what they are doing in this. But just wanted to highlight a couple things. The extent of money, United tripled its reimbursement in value-based arrangements over 3 years to $75 billion at the end of 2020. 1 in 3 enrollees who are receiving care are getting it from value-based care providers. And again, they're doing it through a variety of arrangements, whether it's a bundled payment program, hip and knees, or even other type arrangements. Similarly, Aetna's committed 75% of its spending to value-based models, whether it's episodic bundles, an ACO type arrangement with attributed lives, or even patient-centered homes. So these certainly are not going away, and they're only going to continue to increase through the years. Similarly, I'll talk about Medicaid managed care as well as Medicare Advantage because, again, these opportunities transcend the straight government programs as well as your typical commercial HMO program. So managed care organizations are investing a lot in incorporating value-based into their Medicaid managed care. And so some of the things we're seeing a lot of happen at the primary care level, integrating behavioral health and collaborative care into the primary care space. We're seeing a lot of focus by the health plans on filling gaps in care. So as they identify gaps, certain patients need a certain service, they are more than willing to participate in advising that down to the provider level and having the providers assist them in filling the gaps. Certainly the insurers have their own motivation, and in terms of their scores and their arrangements with the state, but they're definitely willing to participate in these. Health home models have been increasing steadily with Medicaid managed care through the years in the same way to help coordinate that care at the local level. And then you see a lot of alignment and partnerships with FQHCs, the federally qualified health companies, in clinics. So if you're involved in these, there's a lot of different opportunities and different focuses that can be explored. Similarly with Medicare Advantage, as Ryan talked about really early on, Medicare Advantage has continued to grow, and we expect and it will further expand, and more people will be covered in MA plans than they will be with traditional Medicare. And these insurers who have the MA plans are no more willing to include these value-based models with their populations. Some of the other things that have kind of come up is, you see things with chronic special needs plans. So with some changes in regulations surrounding ESRD and chronic kidney disease, and couple that with a historical excessive spend and high medical loss ratios for that patient population, both payers and providers are exploring new arrangements to manage that population better and try and get that cost of care down to something that's reasonable. I'm probably not overstating it if I said patients with some of these chronic conditions, their medical loss ratio was over 125%. I don't think that's overstating it at all. And again, bundled payments are always there too within the Medicare Advantage space. One final point on some commercial trends is insurers and providers are not only joining together in the context of an agreement, but they're also forming joint ventures to run these. So this was one of the headlines I remember seeing back in November of 2020, where the first joint venture between a health system and a health plan to really explore these value-based care arrangements. And we anticipate these arrangements are just going to continue, and that joint ventures will become more part and parcel of how they are arranged. And the joint ventures could have quite a number of participants in them, not just two parties as well.
Great. Thanks,
Lori,
Jonathan.
I think we're going to talk about operational readiness.
I am. And so it appears a few of our bullets are missing. So I'll fill in the blank of the visual aid. So before I start, I wanted to remind you that there's some great resources on the AMA's website on assessment of practice capabilities, which is really what I mean by operational readiness. So kind of two pieces to this, really important to know your numbers. Do you know what your care costs to deliver? Do you know what you're tracking on a quality basis and how you benchmark against others? Do you know what covered lives you're at risk for? And those three things are very important in negotiating and thinking about what type of risk-sharing methodology might you be willing to engage in. And then your organizational capabilities. Can you collect data and report on it on key metrics? Do you have the analytics to help you think about strategies at the point of care to be improving population health? Can you identify and close your care gaps? How engaged are your clinicians in alignment with these objectives? And are you focused on population health from a whole person care perspective and partnering with those in the community that are also even non-medical providers that are engaged in this work? Another piece of operational readiness is really thinking through physician compensation. So have you started your compensation transition to mirror your transition into a value-based care world, or are you compensating your clinicians only on production and fee-for-service type metrics? So how do you balance those objectives? So apologies that you can't see half of those slides, but they all go back to what's on the visual to share. And as you think about operational readiness, I wouldn't think of it as a black and white, we're ready, we're not ready, but really it's a process. You can, once you start down the journey, you'll quickly address other capabilities. So I'm going to kick off on some common value-based care approaches, and then Jonathan and Garrett are going to talk through some of these at more depth. So it may be helpful to visualize these as these are approaches that can exist in tandem with different payers or even within the same payer contract. There are also other innovation that's ongoing with specific payers like self-insured employers that we've mentioned a couple of times now. And there are just other activities that are ongoing that you might not think of as value-based care, like on-site clinics, innovation in what you're delivering through telehealth, concierge medicine. So some of those are highlighted further on the AMA's website with respect to working with employers in your community. So kind of some of the typical approaches is we have our pay for value and pay for performance that I imagine many of you are already engaged in, where they're looking at quality metrics, patient satisfaction, proactive engagement where you're paid on top of your fee-for-service reimbursement. We've mentioned already that bundled payments are another mechanism out there. They can be prospective or retrospective. Shared savings, where you share the upside of an arrangement that you're saving with a payer. And then, of course, shared risk, where you're sharing the downside based on whether you achieve things. And then capitation, whether you're being paid up front a single price for that care, and you're at risk. I think Jonathan had such a great way of saying this earlier. You're at risk implicitly by being in one of those models, whether you're working with other providers or not. So with that, let me turn it to Garrett. I think is going to kick us off on some core issues to navigate with these different models.
Thank you, Lori. So the intent here is to start to outline for you some of the most frequent issues that come up in the context of contracting for any of those models that Lori just mentioned before. And the intent here is to make sure that you're able to identify some of these most important threshold issues while acknowledging, I noticed before there's a question that's been raised, if you have a fee-for-service contract, can you also participate in value-based care? And what we end up seeing most frequently, especially in some of the lower kind of risk tier models like pay for performance, is that the entirety of the structure of the value-based contract is kind of tacked onto this foundation of your fee-for-service existing arrangement. And you use that fee-for-service contract and the fact that you're credentialed and contracted with a particular payer to start the process of then potentially engaging with the payer to establish some of these value-based arrangements. And at the end of the day, why you would do that is, one, it potentially, puts you on a better foothold for engagement with that payer on an ongoing basis. You become a closer partner for purposes of engagement in guiding beneficiaries to you as a provider. You can potentially be designated as a center of excellence occasionally, depending on the type of model that you're entering into. But there are many advantages in any geography. In terms of some of these core issues, I just want to highlight a couple of these because they do come up so frequently in the context of any of these arrangements. And the first, very rightfully, is noted as this idea of bidirectional data sharing and reporting with the payer. Whether you're participating in a pay for performance model or some of the more robust full capitation or bundle payment models, there is a core question of who will be responsible for capturing certain data, what you as the provider will be responsible for collecting and reporting back to the payer, and what you will be getting back from the payer and on what time frame to be able to instruct your performance in the program. One of the really frequent tensions is that some of the gauges of success in any particular model, you may not have an idea of how you're doing until well into the performance year, which makes implementing any sort of real-time corrections to your performance, whether it's on a quality or financial basis, nearly impossible to do on a real-time basis. So it's very important to have access to data, whether it's claims data or more quality-based EMR data, accessible to you to instruct those changes on an ongoing basis. In terms of patient engagement and care coordination roles, there's always questions around whether or not you as the provider will be responsible for outlining the terms of the program, or at least providing transparency into the fact that you're participating in individual programs to specific patients, and whether you as the provider will be responsible for the sort of serving as the hub for coordinating care across multiple providers in the care continuum, or if that will stay the responsibility of the payer or potentially some other intermediary that may help to play that care coordination role. In the context of these cost and quality metrics, they can vary dramatically between program and between type of risk model that you're potentially going to participate in. So knowing at the outset both what the cost and quality metrics are, and then who will be responsible for setting those and how frequently they may be adjusted, become very important elements of negotiating any of these arrangements with a payer. And ultimately, the selection of a payment model, we're going to talk more about as we outline some of the varieties of options that you may face. But there isn't necessarily a sort of cookie cutter option for each one. A pay for performance model can take many different, or it can look very different between payer and can take many different incarnations. In terms of the question that's noted next of whose MSO will you use, this becomes important because it's not always going to be the payer that you look to for administering the program. They frequently engage intermediary entities, or sometimes have the opportunity to engage you and your MSO to help administer the program in more of a sort of joint venture model that Jonathan noted earlier. Finally, the level of risk that you're willing to accept is really going to govern which type of model you end up wanting to pursue. The higher levels of risk will, of course, come with higher levels of reward, but you have to really have a good foundation for data collection, for care coordination, for administering relationships with a variety of providers in order to be successful with some of the higher level of risk models. So there could be opportunities to sort of get your feet wet, proverbially, to look at the pay for performance model as a good starting point. So with that, I'm going to walk through some of the important contractual and program elements of some of the kind of lower tier that Lori included in her outline, and I'm going to hand the floor to Jonathan to talk through some of the pragmatic experiences in the higher level of risk categories. I think you've all seen pay for performance models in many of your existing contracts. It's your traditional incentivization of performance in relation to quality, patient satisfaction, certain reporting if you're able to provide data in relation to various care categories. At the end of the day, the most important kind of give and take in this space is ensuring that there's a clear understanding of the portion of your reimbursement that's being shifted to this performance-based piece, and knowing at the outset of the contract with specificity exactly what your target metrics are going to be and who is responsible for setting those metrics. Frequently, where I see providers come into different issues in this space is when there are discrepancies in who is the ultimate source of truth regarding performance in relation to a particular metric, whether there is an opportunity to audit what you think your ultimate performance was as compared to what the payer may believe in terms of how they've captured it, and who gets to control that process at the end of the year. The most frequent disputes that I've seen historically have been when the provider thinks that a metric has been set, but it was not incorporated into the contract that you've entered into, and it seems like it has changed, and you're kind of trying to hit a moving target over the course of the year. So it's really important to clearly set those targets at the outset and not permit the provider to make kind of on-the-fly changes as the performance year progresses. Next, I want to talk just a little bit about bundle payment models. This is where in terms of my practice, I work the most frequently. Bundle payments are one of the most prevalent models on the federal side. You all may be aware of the BPCI program, which has now been going on for nearly 10 years. The crux of these programs is that you are either receiving a prospective actual set bundle of dollars for an entire episode, which frequently is an initial either acute episode like a surgery and then 30 to 90 days after it, or you're receiving a retrospective target and then either receiving a portion of savings if you bring the costs in at below that target, or potentially taking on risk if you agree to be responsible for overpayments beyond that target price. The most frequent model that we still see today is that retrospective model where you've still got the foundation of a fee-for-service payment coming in, but then at the end of the year or biannually potentially, you have some sort of reconciliation process where you have a true-up in comparison of your performance compared to that target rate. The most important considerations in this space, in my experience, is really, really clearly defining what constitutes that episode. There are so many situations, especially on the commercial side, where they just want to tell you that there's a sort of black box determination of what constitutes the episode, and there's not very much clarity as to what will actually contribute to performance compared to that target price. The other thing that is very important is determining when an outlier will be categorized. And what can so frequently happen in the context of these bundle payment programs is that, as you can imagine, one or two outliers, if they are not excluded from the program, can just destroy your success or ability to succeed in the program. So having very clear rules from the outset that will exclude those intentionally, whether it's if they go above 30 or 40% above an average or some other Windsorization process that may exist, that just needs to be clearly set forth. Finally, I just want to emphasize that in terms of what we see coming down the line, so to say, CMMI has repeatedly emphasized that there will likely be increased opportunities or expansion of the BPCI program in the future. So there may be additional opportunities to enroll in that program, and it may be made more available to providers and provider groups, whereas historically there has been that hospital-centric concentration in this space. With that, just in the interest of time, I want to hand the floor over to Jonathan to talk about population health payments and then broader capitation as well.
Yes, thank you, Garrett. You know, some of the concepts surrounding population health and the value-based concepts we see are primarily in the shared savings and shared savings with downside risk form of model. You know, there are some significant considerations when you're looking at trying to manage a defined population set of patients. You know, as physicians in this area, you know, population health is usually going to look at both institutional and professional spend as part of the benchmark. And so dealing with an institution, you're going to have some considerations of fair market value when you enter into these arrangements. At least the hospitals that you might be participating with will be looking at that. You know, so that's got to be understood from the physician side, that when you're a referral source, some of these partners you have in these arrangements still have to navigate some regulatory risk and concern in entering into those arrangements. But to reiterate what Garrett just referenced with outliers, when you're dealing with population health, essentially, it's really critical to make sure that you define what is going to be excluded from the calculation. You can have a population of 2,000 patients that are in a pool, for instance, and if 2 of those patients or 3 of those patients end up with a transplant, and you're accounting for all their costs and don't have any limits on it, that can really turn shared savings into a downside risk, and do so really quickly. So it's going to be very important to make sure you have those categories identified of what's included and what's excluded. I've seen carve-outs with a percent of charges, or essentially, if a patient incurs more than X amount in the calendar year or the measurement period, you're only going to count the first X amount, and anything above that is excluded from the calculations. Some other things too is you really need to have some bolstered data analytics and the ability to monitor real time, because managing this patient population effectively is key to having success. But with population health, it's harder for insurers to manage a population across a large territory, but employers are getting more and more interested in this, because they're the ones that have the defined set of their employees and their dependents who are covered by the self-funded plan. So look forward to keeping that in mind as you explore these types of arrangements. Similarly with capitation, we've talked about it several times today. Oftentimes it's a per person, per month, or even a year. Another way that this can get calculated and set in advance is a percent of the insurer's premium. And here there's some tricky negotiation that can go on as to what's deducted from their premiums before it's considered the premium that you're receiving. And oftentimes I find providers at the mercy of the payer's actuaries. This takes some sophistication when you get into a percent of premium type arrangement beyond just a PM. And it also has some added layers from the payer's side and their actuaries. But again, there's going to be some assumptions that you need to carefully consider in entering these. The population involved that you're being capitated, the services that are in the scope of the capitation, what is carved out from those services and perhaps reimbursed on a fee-for-service basis. What's the historical utilization of the patient population? You might not know all this. So in a negotiation, you might have to have an NDA, a non-disclosure agreement in place with the payer to find out information on the population. Again, strong actuarial support can come into play and be necessary in order to adequately negotiate and account for all the elements here. And, capitation requires efficient practice standards. You all have timely access standards, timely appointments you need to meet, as well as a population who, a lot of them might need your services all at once. So being able to be efficient in this space is really important, as well as making sure that you're not, incurring more costs than the capitation is providing you for those services. Finally, other risk-based models. I did refer to the earlier with some risk-sharing agreements that might occur between hospitals, physician groups, even insurers as well. You can do withhold arrangements with the insurers where you put a certain portion of your reimbursement at risk, where the payer basically holds the pool and of whatever dollars there. And then at the end of the year, like Garrett was talking about earlier, there's a true up or a reconciliation. But it's very careful to document the allocation of surpluses and deficits. Usually there will be caps involved with any sort of risk pool so that there's not improper payments made from a hospital to a group, for instance. or so that a deficit is not going to put someone out of practice or into bankruptcy. The provider allocation, some of this is really personal preference or need. So it's kind of hard to tell, given such our wide disparity of practitioners here, which area you might want to focus on. But these can differ, and the types of arrangements can differ depending on your service and practice type. I think Lori is going to talk now about some of the tips for selecting the best approach. Lori?
Yep, thanks very much. We're going to zip through the next couple of slides so we allow some time for questions. But selecting the best approach, it really is going to depend on your circumstances and where you are in your journey on value-based care. Typically, you want to walk before you run, so you start with upside incentives and be sure you're ready before you move into anything that is downside. Is the conventional wisdom. Really makes sure you have access to information, as Jonathan mentioned it. For capitation and downside risk, it's really important to have, multiple years of claims data if you're entering into those total cost of care type arrangements. So, and retaining that actuarial support to help you work your way through that. So, as you're planning and thinking about the best approach, I highlighted ongoing communication with clinicians and staff, because if you are in these models, regularly reporting back to the team on your progress is often very helpful, including, thinking ahead to how are you going to incentivize the care team? How are you going to allocate the dollars that you might receive from the payer for your performance? So, like Jonathan, not knowing how many primary care versus specialists we have on the line, I leave to you for those complex conversations. But it's really important to think about that, because they will stymie you as you enter more complex arrangements if you haven't thought through that aspect. We thought that while this is not a presentation on regulatory risk, we did want to at least pause and flag that in this arena there are a lot of risks to navigate, particularly if you are working with other providers, and wanted to flag that there are some new value-based care exceptions in the anti-kickback statute and the Stark Law, as well as the civil monetary penalty context in terms of assisting patients to participate with you in those arrangements. So those are definitely worth taking a look at. They are complex, and you'll definitely want to consult your lawyer around those. So as we wrap up and look to 2022 and beyond, we're going to go do a little back and forth between all of us, and this kind of represents a little bit of our consensus thinking, although I think we have some disagreement amongst us as well, so that may come out. But expect to see more employers enter into the market in direct arrangement. They know the population, they know the occupational medicine type of concerns they have based on the nature of their industry, and they are more and more willing to jump in to try and contain their costs. And be thoughtful about regulatory changes. Some of those are good, like the changes I mentioned on telehealth. So not everything is doom and gloom out there. Jonathan, do you want to pick up on the next two concepts?
Absolutely. Lots of different states, and this is all over the map across the country, but states have various insurance laws related to requiring licensure as an insurer for assuming risk. Some states don't, some states do, some have a mix. So as you enter into these and you take on and assume some risk, especially if you're entering into some of the more advanced type arrangements, it's going to be very important to understand any risks to you as a physician. For instance, if you are participating and sharing in institutional risk, or if you are sharing in, global risk for all. Again, it's all across the board through the country. So depending where you are, you may have laws to worry about in this area. So it's important to be mindful of those. And again, I just want to reiterate this other point. The commercial insurers are going to focus on incorporating the downside risk, and they're going to continue to try and push that downside risk onto participants. Insurers are good at spreading the risk and passing on the risk. And this is one area where, while you may start in an upside only arrangement, anticipate that at some point it will evolve to include some downside risk. And that's where being prepared is very important. And again, commercial insurers are not the only, I should say employers are not the only ones working on direct arrangements with providers in this space. There are some arrangements where commercial insurers will partner with providers and the employers to manage a population or include value-based components for managing an employer's population. It's still a self-funded space. The insurer is serving as an administrator as well as other administrators involved, but these arrangements are increasing and evolving continually. Garrett, I think you were going to talk about some CINs.
Yep. Thank you, Jonathan. And I would also just note on the commercial insurance side, in my experience, it has become a bit of a shell game. And you need to be very aware if you're presented these opportunities to increase your participation in value-based models to make sure that that's not coming at the expense of other more, I'll just say, guaranteed funds flows, which can frequently occur. And that may not be something that you can necessarily control, but very frequently those dollars are coming from somewhere else. In terms of CIN and ACO participation, I do think, as noted here, there's going to be some significant opportunities for utilizing those contracting vehicles for participation with, as noted here, Medicaid managed care, value-based care options, in addition to a variety of other commercial arrangements. Very frequently in the markets where I've worked, payers will be more receptive to contracting through a CIN or ACO that has demonstrated some ability to impact or in some way guarantee performance in relation to either cost control or quality control based metrics. And for that reason may be more receptive to contracting with those entities as opposed to a group independently. CINs are just simply a contracting vehicle where there has been some hub entity formed to permit contracting on the basis of clinical integration, which can involve anything from adoption of common care protocols to full integration of electronic health records. I have seen over the course of the last couple of years, especially, significant expansion in the joint venture space, which can frequently involve groups, larger groups, especially in certain markets, that will come together either with the hospital or with the payer directly to facilitate participation in a value-based model, most frequently bundle payment type programs, where you utilize the existing infrastructure of the hospital or payer, which may have the resources to already provide data analytics services or bundle analytics services that the individual groups may not have, but the groups can come together to provide the clinical and clinical protocol expertise that the payer and hospital can't necessarily replicate themselves. So really be on the lookout for those types of opportunities in your market. And with that, I will hand off the floor back to Lori to close us out along with our colleague Ryan.
Great. So I just want to pause and note that we're expecting to see increased engagement on whole person care and integration. And if you're interested in this area, there's a great recent publication by the NCQA written in the behavioral health space, but it's a quality framework, using a roadmap for using measurement to promote joint accountability and whole body care. It's a really interesting publication that highlights how one makes progress on value-based care through whole body care. So leave that to you at your leisure to take a look at. And we decided we're going to give Ryan the last word. So he's going to wrap us up today. Thank you.
Thanks, Lori. And thanks for joining me again, folks. During just the last year of the value-based care portion to make two very minor but very important points. The first, I think, is that as the value-based reimbursement models become more prevalent and more sophisticated, and as more and more providers get into this space and become comfortable with it, the fee-for-service only arrangements are going to become outdated and will likely be viewed by the payer as areas that need to be addressed very aggressively from a cost perspective. And so my point is that it'll be a disadvantage area for you, and that financially and from a business perspective, the advantages will be in the value-based care space going forward, because fee-for-service will continue to just get slashed lower and lower, or at least not maintain the increases consistent with inflation, which is likely going to increase significantly in the next couple of years. And lastly, success in these value-based programs, particularly ones where there's downside risk, financial risk for the provider, there's a strong correlation between success and data analytics. We see many of our clients in this space engage consultants to help them set up programs and business people to help them track their own data, to understand what they're doing, where they can become more efficient, what types of care processes they need to implement, what's industry standard, because that's changing constantly. And many providers really enjoy the business of really, connecting with patients and providing the care, which is, great. That's your expertise as physicians. But success in these models isn't just providing great care anymore. It's providing efficient care across the whole population, or at least across the group, or within a bundle, whatever the value-based care model is. So data, I think is my closing point on the value-based care 201 portion here.
I do want to say thank you to first our presenters for sharing their evening with us, and then to all of you who are in the audience, and again, spending part of your evening with us. We hope that you found the content valuable. This webinar is recorded, and we will be posting it to our website, the AMA website, within a few business days, and you'll be able to watch that back. And as mentioned earlier, we'll also be publishing a toolkit that is focused on the topics that were covered this evening. So just encourage you all to check that out once it goes live. And thank you again to all of you for spending your evening with us. And I hope you all have a great evening.